Okay, well, anyways, let's start. Good morning.
Morning.
What I want to do is just spend just a few minutes. The last class we met last Friday, no, last Thursday, I was going to do flumazenil and a couple of PowerPoints, and I couldn't get the thing to work. So we fixed it, now it works. So I want to finish up what I was trying to do last week. And I've only got five minutes or so about this. And then we'll start the real work for the day. So anyways, as I kind of tried to touch on last week, and as you know, flumazenil is a specific benzodiazepine receptor antagonist. It's the only one around. It is to benzodiazepines like Narcan is to narcotics, and protamine is to heparin. It's a reversal agent, and rarely used, but it is around, and I just want to mention it. It's almost kind of a crash cart drug. Not really, but that's how often you use it. But anyways, here goes. It's as I mentioned on here, a benzodiazepine antagonist, and reverses any benzodiazepine, but not narcotics. It's IV solution, no big deal. Indicated for the complete or partial reversal of the sedative effects of benzodiazepines. So, in the early days when this was first marketed, we used to use the benzodiazepines for anesthesia. Give 10, 15 milligrams of Versed for induction. Now you can imagine, somebody isn't going home too soon post-op if they got 10 milligrams of Versed, or even Ativan, or even Valium. So this was a little bit more popular at that time. Now we all, 99.9% of our use is Versed. It's short acting, and we only give tiny doses. And so we really don't have to reverse anybody anymore. So, as I mentioned the last time, every once in a blue moon you might get an elderly patient who you gave 1 or 2 milligrams of Versed, and they seem to be, somnolent for a long time, and you want to kind of perk them up a little bit in the post-op area so you can titrate in a little bit of this and see if it works. So that's kind of where it stands as far as a niche use in anesthesia. So these slides talk about reversing general anesthesia and all that, but that's not what we do nowadays. Duration and degree of reversal are related to what dose you give, what's the plasma concentration, and how much benzodiazepine is in there. Well, that's true of any antidote drug or antidotal drug. It depends on, number one, how much you give, and number two, how much of the drug you're trying to reverse is in there. And that will tell you how long it lasts. Doesn't reverse the opiates, ethanol, the barbs, or general anesthetics. And here's 3 different doses. They're just trying to show you that the more you give it, longer it lasts. And this is their baseline level for alertness. And this was, if they gave 0.2 milligrams, they got the patient is never going to be real alert, but they'll be a little bit reversed. Gave 0.6 milligrams. Oop. Sorry. Then they get up here. Patient was alert for this amount of time period. So that's, maybe 30 minutes. And then this is a 1 milligram dose, and you see it lasts longer. So the duration is dose dependent. I mean, that's no shock. And you can get with a full milligram dose, which is the highest recommended dose, you can get it to last this long, which is about 45 minutes. So that's what they're showing on this. Kinetics, the distribution half-life is about 7 minutes up to 15. So it pretty rapidly distributes in the Beta half-life is 41 to 79 minutes. So if you kind of pick the middle of that, the half-life is less than an hour. Protein binding is not an issue. It's metabolized in the liver and cleared. And you completely eliminate it in 72 hours. So this is pretty standard kinetics, and as I mentioned the last time, the only thing that stands out to me when I'm looking at these numbers is that the benzodiazepines are going to last longer than this does. So you're reversing something that the reversal is shorter acting than the reversed, the drug you're actually getting rid of. And they talk about it, if somebody has moderate liver dysfunction, the clearance is decreased because it is metabolized in the liver by about 40 to 60%. The half-life is prolonged to 1.3 hours instead of about 0.8 hour in a healthy person. Are you falling apart over that? No, I'm happy. I wanted to reverse somebody, I want it to last a long time. So the longer it lasts, the better for the patient. So actually, this is an advantage, not a disadvantage. Right? If you're reversing somebody, the longer it lasts, the better it is, right? Severe liver dysfunction, half-life is prolonged to 2.4 hours. So it lasts even longer, and of course that's a good thing, because you're trying to reverse them. Check this one out. Food ingested during IV infusion. So I'm not sure what that means. We don't feed the people in the middle of the operating room. I assume this means in the ER or somewhere. And that increases the clearance. 50% increase in clearance. Why do you think that would happen? It's pretty simple. When you eat, the more blood flows to your liver to digest the food. And the more liver blood flow, the faster you're metabolizing anything else in there, which in this case happens to be flumazenol. So, and the benzodiazepine agonist is not altered. In other words, what you're reversing, the blood level stays the same. It's independent of what flumazenol is doing, and it can probably last longer, and that's what they talk about next. If you're dosing somebody, the initial dose is 0.2 milligrams IV over about 15 seconds. Wait about 45 seconds. I don't know why they picked 45. I'd say wait at least maybe 2 minutes. See if the patient is aroused at all, and then you can just keep repeating. If the desired level of consciousness is not achieved, just give another 0.2 and so on and so forth. You can repeat it in 60-second intervals to a maximum dose of 1 milligram. If you've given 1 milligram of flumazenol and the patient isn't any more awake, then it's not a benzodiazepine that's putting them to sleep. There's some other issue or drug that's making them sedate. Most patients respond to doses of 0.6 to 1. I would say most patients respond to doses maybe 0.4 to 1. Should not be used until the effects of neuromuscular blockade have been reversed. I think this is pretty self-explanatory to anybody in anesthesia. You don't want to reverse the patient while they're paralyzed. Basically is what they're saying. Maybe this is for someone else somewhere in the hospital. We would never do that. So comparing half-lives, there's romazicon flumazenol, 0.7 to 1.3. There's Versed, 1.7 to 2, so it's a little bit longer. And of course, Valium we know is extremely long. If you're reversing Valium, let's say in an ER, then you can bet the patient's going to resedate. So yeah, you can give reversal and get the patient awake, and that will protect their airway a little bit, and they won't aspirate, and they'll breathe better and so on. But you better keep the patient there because they're going to go back to sleep within an hour to 2 hours. When the concentrations wane, the patients resedate. When you're using small doses for conscious sedation, in these clinical trials, 3 to 9% resedated. When you're using higher doses for actual general anesthesia, up to 15% resedated. In an overdose situation in an ER, over 65% patients resedate. So, you got to be careful. Safety information, you don't want to give it to patients with seizure disorders. Most often they're on benzodiazepines because of its anti-seizure effect. So if you're reversing their seizure drug, that's not a good idea for somebody with seizures. So be careful if somebody has a history of seizure disorders, don't give them flumazenil. Contraindications, of course, if you're allergic to it, if people are overdosed on tricyclic antidepressants, there seems to be an increased risk for seizures. And I think that's it. Patients who are physically dependent on benzodiazepines, you don't want to reverse them. Somebody who's been on them for months and months and may have overdosed. Same is true of an opiate addict. You don't want to give them Narcan. You put them into withdrawal, and then that's not very pleasant. So again, repeat doses at 20-minute intervals if needed. Inject 0.2 milligrams per minute, no more than 1 milligram at any one time. That's it. So I just wanted to make sure I showed you that. Yeah.
That last slide you showed, did it say no more than 3 milligrams in an hour or 3 doses?
3 milligrams. No more than 1 milligram at any one time. No more than 3 milligrams per hour. Yes. I can. I don't know if it is, but I'll ask Clinton to do it. I'll put the PowerPoint on my website under the videos. Okay. Cool. So, let's go to work. Page 213. Start with new topics for today. And of course, the exciting new topic for today, hold on to your seats, will be narcotics. We're going to do the opiates next. And they're obviously a tremendously important component of the anesthetic care these days, providing analgesia. As you know, our drugs are pretty lousy analgesics. When you talk about the inhalation drugs, the only one with clinically relevant analgesia is nitrous oxide. And when you talk about the IV induction drugs that we just finished, the only ones with clinically significant analgesia are ketamine and Precedex. So a couple of drugs we have provide some analgesia. Most of the drugs don't. So we have to give narcotics and requiring pretty high doses of analgesia to have surgery. And so the opiates, of course, fentanyl is one of the mainstays of any operation. This picture, and I have a color version of it on the website. This is a poppy plant, and of course I put this here in honor of the fact that morphine and the natural derived opiates come from plant, and they're derived from opium, and we'll talk about that here in a little while. On the next page, as I always like to do, let's talk about the names of the drugs we're going to cover. And we're going to cover more than this, but these are the main ones we're going to focus on. Of course, morphine being the granddaddy of all opiate drugs, and meperidine, which is Demerol, fentanyl, we call it fentanyl. Nobody cares about the trade name. Sufentanil, same thing. Alfentanil, same thing. Remifentanil, same thing. So it's just fentanyl and Sual and Remi. They're all derivatives of fentanyl with different properties, but similar pharmacology. Then the reversal agents, naloxone, of course, is Narcan. Getting a lot of interest in the world nowadays. Marketing it in many different formulations because of the, as you can't turn on television or radio nowadays without hearing about the opiate crisis as far as addiction and overdose and so on. And I will talk about that a little bit too. Naltrexone is another, it's just a derivative of Narcan, but it's a pill. Narcan, of course, is a IV injection drug, and it's nasal. Now they have a nasal form. But naltrexone is similar, but it's a pill. And nalmefene is a long-acting Narcan. It lasts about 8 hours. So these are the one drugs we'll focus on, but obviously we're going to talk about a lot of other things, Vicodin and Dilaudid and the partial agonist drugs, and there's a whole slew of things we'll talk about. But these are the focused ones that we handle most often or give most often. And as I kind of touched on a little bit Friday, or last Thursday, I like this part because this is the part where, although you've done given some of the other drugs, propofol, Precedex, and so on, these narcotics, you give them every day when you went to work. You're very familiar with them. Maybe not looking at them the way we look at them, but you still have good experience with it, so it makes it a little bit easier to talk about. So here we go. Now, let's go to the next page. Here's what happened. Don't put your pens down. We've known that opium has analgesic properties for thousands of years. In the Old Testament, there's references to the use of opium to relieve pain, and morphine was named for the Greek goddess Morpheus, the goddess of dreams, because it produces a dreamlike state when you're getting morphine and so on. So we've known about the use of opiates as pain relievers for forever, for thousands of years. Over the years, of course, we recognize the downsides to the use of opiates, and their use really became a lot more widespread after World War I. They invented a needle so they could give IV drugs or inject IM drugs, and a lot of the soldiers in World War I came back from the war dependent on morphine because they were given it. Everybody walked around with morphine in their packs, and when they were injured, it was kind of a crude thing, but they would try to give morphine to relieve the pain. So a lot of folks came back from the First World War with a dependence problem to these. And so they tried to develop bigger and better, shinier new drugs that would be not addicting. And in fact, Bayer Pharmaceuticals, I have some slides of this I might show you, German company, still around. They developed heroin and marketed it in the United States as a non-addicting substitute for morphine. And this is back in the 1910s, 1920s. You used to be able to go into a drugstore and buy cough syrup with heroin in it. And I've got pictures of the labels on it, about how it'll get rid of your cough. Yeah. But of course, that didn't work out too well. And, in the 1940s, they were still searching for a non-addicting form of replacement for morphine, and they, by accident, discovered Demerol. This is, I think, in Sweden, and they marketed Demerol as a non-addicting substitute for heroin and morphine, and it went on and on. And then finally, when it got to be the 1960s, everybody realized there's no such thing as a non-addicting substitute for an opiate, because of my cardinal rule, which we're going to learn today, and that is the analgesic potency of an opiate drug always is equal to the addiction liability. So the more potent it is, the more liable you really are going to become addicted to it. And we'll talk about that later. Well, in the meantime, many researchers, in fact, in the 1960s, two research groups, one at Oxford University in London and at Johns Hopkins in Baltimore, discovered a substance in the human body, actually in pig ileums, in the chitlins. They discovered a chemical that produced pain relief, and they realized that it's part of the human body as well. So this was the first discovery. Of course, everybody knew that drugs produce analgesia. They didn't know how or why. Then finally, they found a substance, a chemical, in the human body that was a definite analgesic chemical, and then they were able to track what receptor it attached to, and they were able to discover, you know, they were there all along, but to find out about opiate receptors. And the first chemicals that they discovered were called enkephalins. They named them enkephalins because it means in the head. So they knew they were in the head of human beings, even though they found them in the intestines of pigs. So the enkephalins were derived, and soon afterwards they discovered a few other chemicals, endorphins, dynorphins, and so on. So, and they won a Nobel Prize for it, and it was all exciting because in the early 70s then, everybody said, well, this will be easy now. Now that we know what the body uses, enkephalins and endorphins and so on, we can just synthesize those, inject them, and we'll do the same thing the body's doing. Well, as you can tell, you've been working in 2017, and you're not going in the Pyxis and pulling out enkephalins to inject it to anybody. So it never quite panned out. We know all about them, we know where they work, we know the receptors, we sequence and amino acids, sequence the receptor, we know everything you need to know. But we can't get the drugs, we can't use them as drugs. There's too much, there's anaphylaxis and there's metabolism, and you can't distribute them, the solubility issues. So it never really quite worked out to use them as medications. But of course we have a whole world full of knowledge now that we didn't have then. And I noticed President Trump last week came out with a big talk about the opiate crisis, and he called on the science community to develop a non-addicting substitute for heroin and all the rest of the fentanyl, which is one of the abuse drugs nowadays. And I just had a smile at that. Because first of all, believe me, people have been searching for that for, you know, as long as you can. If you get that, you're going to retire a rich person. That drug company is going to be, you know, as big as Apple. But so, and it's, I know the government's innocently asking the drug world to come up with that, but easier said than done, as you'll see. So if you look at page 215, you'll see there's a, in fact, let me go on the camera and point. This is the 2017 knowledge of the body's natural chemicals. Come on, baby. There we go. Page 215. So there are two enkephalins we know of. They're called met and enkephalin, and they're called that because they're actually pentapeptides. They're 5 amino acids long, and the first 4 amino acids are the same in each one, right down on the bottom here. Tyrosine, glycine, glycine, phenylalanine. Then the terminal amino acid is leucine. And then metenkephalin is tyrosine, glycine, glycine, phenylalanine, and the terminal amino acid is methionine. So one's called enkephalin and one's called metenkephalin. And you can see they're really simple chemicals, 5 peptides long. Enterprising high school kid could make it in their garage with a chemistry kit. It's not hard to synthesize. However, you can't really inject them. They don't get to the site of action, they cause anaphylaxis. There's all kinds of issues with their use. But that's the body's own chemicals, and the first ones that were discovered. And they were, the precursor to them is, who's got a pen I can use? Thanks. Is something we call a proenkephalin. In biochemistry, pro means precursor. So there's a proenkephalin molecule in the nervous system of our bodies, and when you release it, it gets cleaved by what's called enkephalinase enzymes into met and enkephalin. And the most places that the enkephalins are found are all those CNS sites. So they're showing hypothalamus, GI tract, sympathetic nervous system, adrenal medulla, etc. Then another group of scientists, a couple of years later, discovered what they named the endorphins. Beta endorphin specifically is the most potent of them. They're also in the human body, and they come from a precursor. They're about 99, I think, amino acids long. And they come from a precursor called pro-opiomelanocortin, and I'm circling it right here. Everybody refers to it as POMC. Now, pro, again, it's a precursor, and the opiomelanocortin, it comes out of the adrenal gland, the pituitary gland, is where it's secreted in response to stress. So when you have a stress response, you release POMC, and then it's broken down into beta endorphin, into cortisol, steroids, and melanocortin, MSH, melanocyte stimulating hormone. And why release melanocyte stimulating hormone as part of the stress response, nobody's really sure. It's supposed to be having to do with pigment, but it must obviously have something to do with something else as well. So the POMC, the pro-opiomelanocortin, is named that because that's where you get beta endorphin from. Now, lastly, they've discovered all the other molecules, the dynorphins, and now there's some discussion of there being what are called endomorphins, although their site of action hasn't been characterized too well. So there's basically three groups that are well studied, well recognized, and everybody agrees upon, and that's the enkephalins, the endorphins, and the dynorphins. All of us have them in their body. They're all released somewhere in the nervous system axis and in the GI system in response to stress and pain. And these chemicals are our own drugs used to treat pain, analgesia, produce analgesia. The biggest group of opiate receptors in the body is in the GI system. So the pharmacology of the narcotics, you'll notice, always revolves around central nervous system effects, what happens in the brain and spinal cord and the pain pathways, and GI effects, because there's so many opiate receptors in your gut. Probably more than there's in the brain. So you'll see when we do the pharmacology of the drugs, we're always referring to the GI effects and the nervous system effects. All right, so let me summarize. There's three well-defined chemicals in the body that we know the body uses itself for analgesia, treat pain when it happens. They're referred to, they are the enkephalins, enkephalin, the endorphins, and the dynorphins. Okay? Now on the next page, you notice I just put in there, these are the related peptides, metylenkephalin, dynorphin A and B, neodynorphin, endomorphin, etc. So there's a little bit more specificity than we have to care about. On the bottom, it shows their precursors. There's POMC and how it's broken up into ACTH and so on. Proenkephalin, prodenorphin. Can't imagine how much you care about that. About as much as I do. Okay, so we have a chemical to produce pain relief. It's got to have a receptor to work on it. That's an obvious. So the opiate receptors were discovered at the same time, back in the 1970s and 60s, and they've been pretty well characterized, and we know we can make them, artificial ones. We know the exact sequence, how they fold up, and we'll see how we get a little farther in all about that. But if you go to page 217, I took this diagram from I don't know where, but I kind of liked it because it talked about the different drugs that can produce pain relief and where they kind of work. So I'll start with reading on the right-hand boxes there in page 217. And in the brain, they mention opiates, alpha-2 agonists like Precedex, that's again analgesia, centrally acting analgesics, aspirin, acetaminophen, the NSAIDs, etc. Local anesthetics work wherever you inject them, so they can be anywhere. Peripherally, opiates also have work, so do alpha-2 agonists and the NSAIDs. At a local tissue level, they also can affect everything, and they're showing that there. The pain impulses originate in the tissues is what they're trying to show, and the receptors that recognize pain or produce pain are called nociceptors, NOCI, and the nociceptors respond to the release of pain chemicals, substance P, and bradykinin, and some other chemicals. They get stimulated, they send a signal up the spinal cord into the brain. If you haven't had this yet in anatomy and physiology, you'll learn it in detail from someone else, not me. But the pain pathways in the spinal cord, the tracks in the spinal cord that where pain pathways go, are called the spinothalamic tracts. From the name you can tell this means it goes from the spinal areas to the thalamus, and the thalamus in your brain is the kind of the relay center. It's like sitting in there figuring out where to send the signals, and so the thalamus then sends signal to all the different parts of the brain to let you know that you just hit your finger with a hammer, or you stubbed your toe, or the surgeon cut your knee, or whatever the pain-producing thing that happened. Then you have a response to it. And so you send the signals from the brain down through the spinothalamic tracts back into the periphery to pull away. There's reflex actions to yell ouch and be in distress. And you get action sent to the brain stem, so sympathetic catecholamines get released, and you get tachycardic, diaphoretic, and you start breathing faster, and all the things you're familiar with when somebody has a pain response that occur from the periphery into the brain and then back out. So this figure, I just thought it was a nice way to show that all the way from the brain down to the tissues and then back up into the brain, there's a lot of different drug intervention points that you can give analgesic drugs to try to minimize it. So let's see what the guy says here. Multimodal therapy for pain relief with or without opiates is not accepted as a more balanced approach. Such therapy aims to decrease the dose of any single agent, improving anti-nociception, and reducing side effects. Well, there's a theme we've seen before. Give tiny doses of multiple drugs rather than a high dose of a single drug, because it's easier to wake the patient up and send them home. and there's less side effects. So we'll get into that. Here's a question. What do we have pain for? What is pain in the body? You spent all your life chasing it around. When they put the button on for the nurse, give me a shot of morphine. I got pain. What is pain? It's a warning system, exactly right. Pain is a warning that there's some tissue damage. There's something bad going on somewhere, and it's trying to warn you that you need to address it and get rid of the source, or at least mask it by giving some pain relief issue. But pain is an alerting system, a warning system, to let you know there's tissue damage or something happening that you're not going to be happy about, and to try to make you address it. Now the chemicals, of course, as we said, have to have somewhere to work, and so we've named the receptors for analgesia, the opiate receptors, after, of course, morphine. And if you go to page 218, see on the top, we now officially have kind of settled on 3 different opiate subtype receptors. One is called a mu receptor, mu, it's from the Greek letter M for morphine. So the mu receptor, and the second type is called a delta receptor, and the third type are called kappa receptors, all with Greek letters, mu, delta, and kappa. Now on the top of page 218, to say they're the Greek name, which is mu, kappa, or delta receptor. There's an ORL1 receptor, which is synthetic. It's not defined yet, so nobody cares about it. So just the first 3 are the ones we care about. Now, the International Union of Basic and Clinical Pharmacology, it's a group of old pharmacologists that go meet around the world and officially name receptors. Oh, that's exciting, isn't it? That'd be quite the convention to do. And they want all of us to call them MOP for mu opiate receptor, DOP for delta, KOP for kappa, but nobody pays any attention whatsoever to them, and they call them mu, delta, and kappa receptors. And then the ligands, the analgesic chemicals that prefer which type of receptor, we'll see that beta-endorphin and metanolin-keflin are mu receptor agonists. Metanolin-keflin will also work on delta receptors, and dynorphin is primarily a kappa receptor agonist. If you look at the back 2 pages, I'm sorry, back 3 pages, page 215, in the table, the last column, anatomical locations, you can see that somewhere, there's mu receptors and kappa receptors, they overlap. Some areas have more mu receptors than kappa, some places have more kappa than delta. There they are, see the anatomical locations on 215. They're the pituitary gland, the locus coeruleus in your brainstem, all the axis of the CNS and spinal cord. And we're never going to learn that. We don't care, right? A lot of people do, a lot of researchers do, but all we need to know is they work in the brain, spinal cord, and GI system. That's basically what we care about, because when we give drugs, that's where they work, in all 3. So which one receptor has higher affinity for which enkephalins or endorphins, and it doesn't matter. The clinical people, we're given IV narcotics, and we just need them to work CNS, spinal cord, GI system. But there are people that study this and spend a lot of time worrying about it. Okay. Now, if you want to go to page 219, I want to show you this little drawing. Page 219. question, of course, will always be, how do they work? And here's the answer. So if you go to page 219 at the top, this is a very crude, as you can tell, almost a stickman drawing, but I like it because it's about as complicated as you have to get to understand how they work. So here's what happens. You have pain pathways, as I said, that run from your tissues. The tissue gets damaged, it releases prostaglandins and leukotrienes, substance P, several other chemicals. They stimulate nociceptors, and that sends a signal up your spinothalamic tract to the brain that you have pain. And then it sends a signal from the brain down to how to respond to it. And plus emotional response and physical response and tachycardia and all that. Well, all along the pain pathways, everywhere you have a pain nerve, you also have an anti-pain nerve. So they run together. You have a way to produce pain, you have a way to get rid of pain. Just like you do everything else in the body, right? You always have a way to make your heart rate go up, and you have a way to make your heart rate go down. Breathe faster, breathe slower. Well, just like with the pain, you got a way to produce pain, and you also have a way to decrease pain. You can't, a lot of times, decrease it enough to get you out of pain. We can certainly do that with drugs. So the pain pathways also have these enkephalin, they're showing here, containing neurons. So this is supposed to be an enkephalin neuron that's running right collateral to the pain pathway. And what happens is, this is endorphins, okay? And here's a pain pathway, this coming down this way. So this got my pen that works. This is going to release these pain chemicals. They're saying in this system it's substance P into the synapse. It attaches to a substance P receptor, and that keeps the pain signal going. So it jumps from nerve to nerve to nerve all the way up to your brain. So this is a pain signal. Now what happens is the collateral anti-pain neuron contains endorphins, and they get released and attached to an opiate receptor that's on the presynaptic pain neuron. So pain nerves in their presynaptic, right here, have opiate receptors on them. And when you release endorphins or enkephalins or dynorphins, and they stimulate these opiate receptors, then that decreases the amount of the pain chemical that gets released, and it causes analgesia. So the same strength pain signal releases less pain chemical, so therefore you have less pain. Does that make sense? So let's look, they're trying to show that down here. This is a pain signal from the periphery. It's coming along that nerve, shooting up your spinal cord. See here, pain from the periphery. And then it's supposed to release substance P. There's the substance P receptors on the next nerve, and then they send the signal along. In this case, there's a endorphin-containing neuron releasing endorphins, attaching to the opiate receptors. That blocks the release of substance P, and therefore you have less pain. Did everybody see that? I know it's a little crude drawing, but I kind of like it because it simplifies it down to really the essence of it. That is the pain chemicals, enkephalin, endorphins, and dynorphins, work by inhibiting the amount of pain producing chemical that's released in that pain neuron. Therefore they cause analgesia. Does that make sense? So the opiate receptors are, among other places, they're on the presynaptic neurons, pain neurons, and when you stimulate them, they cause decrease in pain chemical release. Now, when I give morphine to somebody, it comes here, attaches here on these opiate receptors, and decreases the amount of pain chemical that gets released, just like the enkephalins, endorphins, and dynorphins. So it just mimics the action of the body's own substances. And that's how the opiates work. So morphine, Demerol, fentanyl, Sual, Remy, all of them, they're agonists at opiate receptors, and they stimulate the receptor to decrease the amount of pain chemical released. Even though they're stimulating the receptor, you're getting less of something. The stimulation is causing less pain chemical to come out, and that's producing analgesia. Okay, so everybody with me so far? Let's take a break. Okay, on the top of page 220, this is a little more elaborate drawing than the stick and ball drawing in the previous page, but nonetheless still talking about the same thing. And this is trying to show the nerve cell membrane containing opiate receptors, etc. So, well, let's take a look. Here's a lipid bilayer, and this is an opiate receptor. You see the little part that sticks out into the periphery, then part that sticks inside the cell, and when you have an opiate, binding site is here. So an opiate drug, morphine, fentanyl, whatever, Vicodin, are given, stimulates the receptor, and that in turn causes all these changes inside the cell to decrease the release of pain chemicals. We don't have to get into every one of them, but let's read what the person said. Opiate mechanisms of action. The endogenous ligand, or a drug, so in other words, enkephalins, endorphins, or dynorphins, or a drug, binds to the opiate receptor, activates a G protein, resulting in multiple effects that are primarily inhibitory. The activities of adenyl cyclase and the voltage-dependent calcium channels are depressed. Potassium channels are also affected, and so on and so forth. So these multiple biochemical events that occur inside the cell once you activate an opiate receptor all lead to an inhibitory response. Okay? Then at the bottom of the page, 220 again, is just a box talking about the different chemicals and receptors. So the receptor classification of opiate receptors is defined by the International Union of Pharmacology. And there's a mu receptor. The endogenous ligands are listed, the endomorphin, dynorphins, and enkephalins, and where they tend to be in highest concentrations. Kappa receptors, their ligand and where they are, and delta receptors. So, kind of went through that already. Okay, let's go to page 221. And again, let me stop for a second and just mention this. So don't write, just let me talk. We have drugs, certainly we, being the anesthesia community, has extremely potent analgesic drugs, but everybody else has drugs that do this as well. And that is that we can relieve all pain. That's not an issue. You can get rid of anybody's pain with the current medications that are around. The problem is they won't breathe. It makes them stop breathing. So when you give high enough doses to produce 100% analgesia, you also get apnea, respiratory depression, the number one undesirable effect of any opiate drug. So yeah, we can give drugs. We give fentanyl. You know, you give somebody 5, 6, 7, 10 mLs of fentanyl, you know, or 50 mics at a piece, so you give 500 mics of fentanyl to somebody the first 30 minutes of a big case, and they're not breathing. They're not going to breathe. We don't care because we ventilate them anyways. So intra-op, we don't really worry about respiratory depression because, as a matter of fact, we kind of like it. I'd rather not have the patient breathing because I can ventilate them however I want to. They're not fighting the ventilator. They're better synchronized. I'm paralyzing them anyways with rocuronium, so they're not going to breathe for that either. So it's kind of a moot point. It's an academic point for us. Are they respiratory depressant or not? Where it's a real factor clinically is post-operatively. In other words, we have to get the patient back breathing enough to go home within 60 minutes of the time they hit the PACU. So we have to make sure that, yes, we can give them profound analgesia so the surgeon can do anything up to open heart surgery and saw the sternum in half with a power saw and all that stuff. The patient doesn't respond. But then again, we have to get the patient awake at the end. So our challenge with the respiratory depression part of the opiates tends to be in PACU. Not always, but almost always. That's what we worry about. But the real world, medical world, they have to worry about giving enough analgesia without producing significant clinical respiratory depression. And we're going to talk about how to do that a little bit later. So the wish has always been to come up with an opiate that could produce the analgesia. We already have that, that's not a problem, but without respiratory depression. That's the key point. And so in animals, mice, rats, and a couple of lower species of animals, they've been able to do that. They've discovered that there are subtypes of the mu receptor. So, first of all, and I'll give you my cardinal rule, and this is always going to be the same, and I'm going to say it over and over again until you throw something at me, but the amount of analgesia you get from any opiate drug is always equal to the amount of respiratory depression that you're going to produce, and that's always equal to the addiction liability. How addicting is the drug? Those three things go hand in hand. Analgesia potency, respiratory depression ability, and addiction liability. And why do they go hand in hand? Because they're all produced by the same receptor at the same time, mu receptors. So by stimulating a mu receptor with a drug, this is what I'm going to get. However, in some lower animals, they were able to find out that there's actually a mu1 receptor and a mu2 receptor. And they could stimulate the mu1 receptor and not get the respiratory depression if they could get a drug that's specific to mu1 and not mu2. And that's a big discovery. If you can come up with a narcotic that doesn't cause respiratory depression, you're going to cure the opiate overdose problem in America right now, the world right now, number one, because they won't stop breathing when they shoot drugs. And number two, it's going to be immensely useful in the hospital, where you don't have to worry about that happening. But we don't have that now. And in humans, we haven't been able to come up with a mu1 or mu2. It just seems to be so far discovered in lower animals. Now, if you look on page 221, this is a chart. Dr. Hupka, I mentioned a pharmacologist that works with me in this class from Westminster College in Salt Lake City. And he made up this chart, and so look what he says at the bottom. The information presented in this table has been gathered from various references. Much of it from animal studies may not be 100% valid in humans. It's a good summary of the present concepts about opiate receptors. It should be noted that some animal studies has been obtained suggesting there may be subtypes of mu receptors. However, these observations have not been validated in humans. So it seems a promising avenue to explore. So far, haven't got far enough down the road to find out whether it can actually be done. So anyways, let's take a look at the three different receptors and what actions they produce. And these are the actions of the opiates. So, and you know, not to be too fancy word-wise, but these are all the effects of opiates. Some are desirable effects, a lot of them are undesirable. When they're undesirable, we call them side effects. They're all just effects of the drugs. So let's go through this. Mu receptors. Well, they produce analgesia, both at supraspinal and spinal level. Supraspinal means in the brain, above the spine, and spinal cord levels. Mu receptors produce euphoria and sedation. So they make you dream. That's where morphine comes from, the dreamlike state of morphine. Kind of sleepy, but it doesn't put you to, not an anesthetic, but it makes you sleepy and dreamlike, euphoric. Of course, physical dependence, respiratory depression, those things go hand in hand. Meiosis, pinpoint pupils. We'll talk about that more as we go through the next couple weeks. But it's a prominent effect. You'll notice in anesthesia at the end of the case, everybody's always looking in somebody's eyes, what they're looking for, how pinpoint their pupils are. Because if they're not pinpoint, they must not have a lot of narcotic around, and so maybe they can get them breathing, get them awake, and get them extubated, which is, of course, our goal, right? Constipation, major side effect of opiates, not something we deal with in the OR, but it is one of the biggest problems with prescription opioid drugs. Urinary retention, bradycardia, pruritus, of course, itching, and so on. That is a very big prominent problem for us as well. Not especially in the OR, but when we use post-op PCAs and little machine gadgets and so on, where we're infusing narcotics, very often the patient gets itching and we have to deal with that. We'll talk about it. Skeletal muscle rigidity, which is pretty much a problem which only occurs for us in anesthesia because of the doses and the speed we give them. Biliary spasm, which is an issue we'll talk about. And the agonists for mu receptors are endorphins, morphine, synthetic opiates, etc. And the antagonists are always the same. Narcan, naltrexone, which is the pill for Narcan, and nalmefene, which is long-acting Narcan. And the narcotic antagonists work at all the receptors equally. They reverse any effect of an opiate of any kind. Mu, delta, or kappa, it doesn't matter. If you give Narcan, you're going to reverse it. Okay, let's look at the kappa receptors. They also produce analgesia, supraspinal and spinal. However, they produce dysphoria. And what some people will tell you when they get narcotics, if you've ever had surgery and had the opportunity to receive narcotics for pain, some people get a very bad feeling from it. They get agitated. They don't like the feeling. They get dysphoric. And unlike the euphoria that most people get, they experience the opposite. They don't want it anymore. They don't like the way it makes them feel, etc., etc. And that's because of a kappa receptor effect. The kappa receptors has low abuse potential. They also produce meiosis. They have an anti-shivering effect, and we talked about Demerol being used for that. And I will talk about that more as we go through this next couple of days. The delta receptors also produce analgesia, supraspinal and spinal. Physical dependence, respiratory depression, constipation is minimal, urinary retention. So these are the prominent effects, first of all, of opiates in general. This is what they do. And secondly, there's a little bit of differentiation between the mu, kappa, and delta. And I'm going to tell you this now. The test 3, we're going to do narcotics, of course. And if I ask you on the test, what receptor produces what, except for a few things, you're going to answer mu. That's it. It's mu receptors. I can't be any more clear. Please circle the answer that says mu receptors. Somebody on the dark. See, and I kind of joke, but what happens is, I'll say which receptor produces analgesia. Well, kappa receptors do, and delta receptors do too, but the mu receptors do the most. So somebody else give me delta receptor and I'll mark it wrong, and then they'll send me an email. But the book says, so don't do that. I'm telling you. Just write mu receptors. The exception is going to be if the patient has dysphoria, that's a kappa receptor, and the anti-shivering effect is kappa specific. Otherwise, always say mu receptors. You'll be right. Yes.
So the agonists for the mu receptor, you have endorphins, morphine, synthetic opioids, but would there also be some enkephalins? Because on
Yes.
218 you have net-blue enkephalins.
They're all agonists for all the receptors.
Okay.
But they may predominate in one area of the brain, one receptor. It's very complex. But they all work on all the receptors, and all the agonists work on all the receptors. So that's a good question. Okay, next page. Page 222. Let's talk about classification. How do you classify the opiates? So first of all, let me get this on the screen. You can classify them, and we do very prominently, according to their efficacy. So let's see what we're talking about here. This is percent effect versus increasing dose. So that's a dose response curve. And what we're looking for is analgesia. And there are drugs that will produce 100% analgesia. We call them full agonists. Morphine, Demerol, Dilaudid, fentanyl, Suel, and Remy. All of our drugs, they're full agonists. There's a second class of drugs that we call partial agonists. Some books call them partial agonists / antagonists. Partial agonists. And you can see the difference is they cannot reach 100% efficacy. They have a ceiling to their effect. No matter how much you give, you can't get any higher than this amount of analgesia. So they plateau out. And the big one that's used most often is Buprenex. It's probably one of the most prominent drugs for opiate withdrawal. And it's also used, anesthesia people use it sometimes. There's other ones, Talwin, Stadol, Nubain, most of all. Buprenorphine or Buprenex is the one that's most commonly used. It's a partial agonist. Now, what happens is this. It's a little tricky, so stay with me. The reason they call them partial agonists and antagonists is this. So you're working in a floor, patient's light goes on, oh nurse, I'm having pain, give me something. So you go down and you give, 10 of morphine, we'll pretend. So the patient gets, maybe this much analgesia. You get the patient up to there. They get some pain relief, but they still have some pain. So they put their light on, and they go, nurse, I still have pain, give me more. So you say, okay, I'll switch and I'll just give them a shot of buprenorphine. So you give them that, and now they get this much analgesia. You're giving two drugs, but the second drug reversed the first drug. It acts as an antagonist to the first drug. Why? Because it's only got partial efficacy. If that's the one you just gave, you actually make the patient worse. Then the light goes on again and you go on a coffee break. And somebody else did. Now, if this patient goes here and then wanted more and you gave another dose of morphine, pushed them up to here, then they're going to be happy, right? You cause the pain to go away. See what I'm saying? So, if I just give buprenorphine by itself, I'm going to get analgesia. So it's an agonist, partial agonist. It's a crappy one, but it's got some analgesia to it. But if I give it following a full agonist, then it becomes an antagonist. So it's situational. Depends on how I did it clinically. See the difference? Give it alone and it's an agonist. Give it subsequent to a full agonist and it acts as an antagonist. Actually cause reversal. Now, the third group is of course the antagonists. You see the amount of efficacy they have is zero, of course. They have no efficacy. That's Narcan and Nalmefene and so on. So they're pure antagonists. So there's classification of opiates. You can classify them according to their efficacy in three different categories. Agonist, partial agonist, and antagonist. Does everybody see why? Cool. Now, the other way to classify them, let's go to the next page, 223. And again, this is a table that was graciously made up by Art and sent it to me to include in the book. And what we're talking about is the classification of the opiates and the opiate antagonists, and so on, according to their chemical structure. This is the most common way to do it. This is according to their chemical class, or chemical structure. And there's several reasons why we need to know this. You're going to know this from now on, and you'll see why, and it's not that hard. All right. So first of all, let's start at the top. I'm on page 223. There's a group of drugs that are called phenanthrene alkaloids. An alkaloid in chemistry means it's natural occurring, comes from a plant, contains nitrogen, and it has pharmacologic effects. That's what an alkaloid is. So the phenanthrene alkaloids is, the prototype is of course morphine. So you take a poppy plant, you get the tar out of it. If the tar contains several chemicals, I forgot the exact number, it's somewhere in the teens. And one of those chemicals is morphine, another one's codeine, and there's several others, papaverin, dextromethorphan, some others. But it's natural occurring from a poppy plant. Morphine and codeine come directly from that. And their structure is called a phenanthrene structure. I'll show you that tomorrow. And so they're called phenanthrene alkaloids. These are drugs with natural occurring, have pharmacologic effects, and the prototype, of course, is either morphine and codeine, both of which are phenanthrene alkaloids. That's their chemical classification. Now, there's a whole group of synthetic, semi-synthetic phenanthrene alkaloids, semi-synthetic, where they take the phenanthrene, natural occurring morphine molecule, and then just mess around with it a little bit. Put a little group on here, take a little group off of here, take it in the laboratory and just kind of mess it up a little bit. Come up with different drugs. And these are probably the most prominently used, one of the most prominently used types. You can see diacetyl morphine, they put two acetyl groups on the phenanthrene structure and you end up with heroin. Hydrocodone, you put ketone groups on it, it comes out as Vicodin, or hydromorphone, that's Dilaudid, oxycodone is Oxycontin, etc. So all these drugs you're familiar with are all semi-synthetic phenanthrenes, the chemical class. And then lastly, there's a group of synthetics purely man-made by a drug company, and that includes levorphanol, butorphanol, nalmefene, etc. And there you go. There's another class called benzomorphans, that's a pentazocine, that's Talwin, which nobody really cares about anymore. I think it's still on the market, but almost never use. So let's stop and review. There's a group of drugs called phenanthrene alkaloid narcotics, classified. That includes the natural occurring and the semi-synthetic drugs. Morphine, codeine, heroin, Vicodin, Dilaudid, OxyContin, etc. They're all agonists and they're all in that same classification. Some are natural occurring, some are semi-synthetic. Alright, everybody with me so far? Now look at naloxone, naltrexone, etc. are also phenanthrenes, but their molecules altered to become antagonists. So Narcan's an antagonist, even though it's a phenanthrene structure. Now, the second group are called the pyridine drugs, and as Art puts in this little box, although not technically correct, all these agents are often referred to as phenylpyperidines. In most pharmacology books, in my textbook, in the chapter on opiates, it's in there because I wrote it, I know, these are called phenylpyperidines. Clinicians generally call this the phenylpyperidine class of drugs. The prototype for this is meperidine. Methylphenylpyperidine is what it is. It's, of course, Demerol. Right. Other types of phenylpyperidines are fentanyl, Sual, and Remy. So that's that group. Then number 3, he mentions there's another class of drugs called the methadone derivatives, which, guess what? Methadone is of that class. Now, I'm going to go through this again, but I want to tell you why we care. All right. First of all, number 1, if you're allergic to a if you're allergic to a phenanthrene narcotic, you're allergic to all phenanthrenes, but you're not allergic to the phenylpyperidines or the methadones. That's number 1. So there's cross allergy within the classes, but there's no cross allergy between classes. Is how the pharmacology folks would say it. So if the patient tells me I'm allergic to morphine, what can I not give the patient? I can't give him codeine, I can't give him Dilaudid, I can't give him Vicodin, I can't give him heroin, of course, and I can't give OxyContin, etc. Because if you're allergic to one, you're allergic to all within that class. But what can I give the patient? Well, I can give the patient Demerol, I can give fentanyl, Sual, Remy, any of those. Because there's no allergy.
So if the patient says, I'm allergic to morphine but not Dilaudid, then?
They're crazy. and you hear it all the time. And that's a good point. And as he said, the patient says, I'm allergic to morphine but not Dilaudid. And you hear that all the time. And here's why. When you give somebody a narcotic, the normal effect of that narcotic is what? Nausea and vomiting? They all produce nausea and vomiting. That's we call it an adverse effect. The drug is just an effect. They cause itching, especially in your blush area, up in the upper chest and your neck, and so on. They get itching, they get a rash, they get nauseated, they can sometimes be dysphoric, they feel a little funny and their head's spinning a little bit. And if you get a drug and all that happens, what do you say? And you're a layperson. I'm allergic to it. I got a rash, I got itching, I got throw up, and it's a pretty good sign I may be allergic. So, and it's not an allergy. That's the normal effects of morphine. So you got to convince them that, well, you don't have to convince them, just give them whatever you want anyway. I'm telling you, I'm a CRNA, that's why they're all asleep anyway, they do what you want. But that's why they can be confused. Because maybe when they got the other one that didn't happen, so they don't, I'm not allergic to Dilaudid, but I'm allergic to morphine, or so on and so forth. So it's very difficult to tell by history whether a patient is actually allergic to what they're telling you they're allergic to. There are true allergies, but they're pretty rare. There's a lot more people who think they're allergic to morphine than are allergic to morphine, but it does occur. All right. So, anyways, back to my story. There is no within class allergy. I'm sorry. Let's start again. There is within class allergy. If you're allergic to phenanthrene, you're allergic to all the phenanthrenes. But there's no between class allergy. If you're allergic to Demerol, you can still get morphine, etc. Okay, number one. Number two, histamine release. The phenanthrenes produce histamine release. The phenylpiperidines do not, with an exception of Demerol. I'll say it again. The phenanthrenes produce histamine release, which means you can get the rash, you get hypotension, you get tachycardia, all the things that go along with getting histamine release from the phenanthrenes. They all do it. And the Demerol. So the phenanthrenes plus Demerol all produce histamine release. The other phenylpiperidines don't. So fentanyl, Sual, and Remy, our drugs, they don't produce histamine release. Now why do we care about that? Well, if somebody's asthmatic, you don't want to give them a drug that causes histamine release because it's going to cause an asthma attack. So which are likely to cause the asthma attack? Well, the phenanthrene drugs and Demerol, and not one of the other phenylpiperidine analogs. Fentanyl, Sual, Remy, methadone's okay, etc. Okay? So let me wrap all this up, say it one at a time. One of the common ways to classify narcotics is according to their chemical structure, and we're going to look at chemical structures tomorrow, not today. And the chemical structure that's most common is the phenanthrene structure. That's the natural occurring drugs, morphine and codeine. And they also semi-synthetic phenanthrenes, including the very commonly used oxycodone and hydrocodone, heroin, and dilaudid hydromorphone. The phenylpiperidines, which is Demerol, fentanyl, Sual, and Remy, are other class of drugs called phenylpiperidines. And a third class is methadone. There's a few other classes, which he didn't put them on there because nobody cares. They're not really used that much anymore, so he tried to keep it simple, and it's good. So he writes in the box on the bottom then, the three major chemical classes listed are structurally different, their chemical structure is different. Therefore, cross-allergic reactions are less likely to occur between the major chemical classes. If a true allergic reaction occurs with a drug from one class, select a drug from a different class. And then lastly, notice this asterisk on the bottom in bold. Agents most likely to stimulate the release of histamine, and he lists up in the top morphine and codeine, and it would be true of all the phenanthrenes, although they're a little less than morphine and codeine, and Demerol, but none of the others. Okay. Any questions? All right, let's go to the next page, 224. Now, I want to talk about potency a little bit. And so let me just say this. When you figure out, don't write anything down, just listen. When you talk about the potency of an opiate, analgesic potency of any drug, actually, it's a very precarious topic because the perception of pain relief varies so widely among patients, among all of us, humans. So trying to determine how potent an analgesic drug is very difficult. For example, you have patients, you've had this your whole career, where you go in and let's just say start an IV. You know, the patient's screaming like you're cutting their arm off or something. It hurts so much. Then you have another patient where you're in doing something that's obviously very painful. You feel bad for them. And they're just as stoic as can be. They're just sitting there, you know, biting the lip, not saying a thing. Oh, nurse, I'm fine, you know, this and that. They're both experiencing pain, but their outflow, how they respond to the pain emotionally and physically and so on, is much different depending on a lot of factors, cultural factors, human factors, sociological factors, etc., etc. So, when you do drug studies, to try to just look at analgesia with none of the other emotions or other feelings or physical manifestations, just want to get an analgesic potency, it's pretty difficult to do. And you certainly can't do it in humans because we're too complex to be able to do that. We have too much of a scale of responses. And even though they use the smiley faces, you know, how much pain are you in, point to the pain relief, you know. That's not too scientific, a little less scientific than we would like, although what we do isn't much better anyway. So there's 2 tests that are standard, required by the FDA to look at analgesic potency, and they're all done in rats. And the one test is called the tail flick test. And what it is they have a little apparatus and they put the rat in there. They lay his or her tail in a little groove. And they have a laser beam that you can change the intensity. And you just beam a laser into their tail and they flick their tail out. When the intensity of the laser gets to be enough where they don't like it and then they move their tail. Then you give them an analgesic drug and see how much more intense you can turn the laser on until they flick their tail out of there. That's called the tail flick test. They have a hot plate test, and you can imagine this one, it's true.
Oh my
They have a little apparatus, it's like a cage, and the floor of it gets heated up. You can heat it up at certain temperatures. You put the rat in there, and then you heat the floor. They, don't like it. They bounce around. Then you give them analgesics and see how much more thermal insult they can take, and that's called the hot plate test. And in fact, you'll see in the anesthesia journals, in fact, last month I was looking at anesthesia thing, and they had a thing, the tail flick test for this new drug, RO7444, how it responds, blah, blah, blah. So, I mean, these are reported tests and because the rats have no emotion involved, it's more pure response to the pain, and so this is more of a common thing. So this is a whole way of going about my point that I'm going to say, and that is the potency of opiates is tremendously variable in humans. But what is this much potency in one is going to be totally different in another. Just because the emotional response is going to be totally different. So I have these, let's look at page 224. Here's the potency ratios for the different narcotics. But again, you have to take these kind of with a grain of salt. And so first of all, we just give morphine the number 1. So just to start out with, they go 1 milligram of morphine. How does this compare to 1 milligram of morphine? That's the system, the way the system works. So read what I say on the bottom there. Potency ratios are estimates relative to morphine as 1 in purely guidelines. Doses are variable depending on the patient's condition and other drugs administered. High-dose opiates do not provide all the requirements of general anesthesia. You can put a bunch of narcotics into somebody, but it doesn't guarantee they're asleep. You got to give them an anesthetic and make them unconscious too, and so on. So, anyways, let's take a look at morphine. The potency ratio of morphine is 1, of course, that's what we'll start out with. That's the system we devised. So what's Demerol? Demerol's potency is 0.1. What it means is, Demerol is 1/10 the potency of morphine. Well, 10 milligrams of morphine is similar to 100 milligrams of Demerol. It makes sense to you, right? You've all done that. So Demerol is about 1/10 the potency of morphine. Look at fentanyl. It's about 100 times more potent than morphine on a milligram per milligram basis. Look at Sufenta, 500 to 1,000. Well, that's a pretty big range. But let's say 500 is usually what people use, the number. So it's 500 times the potency of morphine. And Sufenta is the most potent opiate on the market. It's pretty much exclusively used by us because nobody else can deal with the consequence. You give somebody 50 mics of Sufenta and they go apneic right away. That's 1 ml. So you got to be ready for that. You got to be able to intubate him, and you got to be able to, whatever, all the stuff that we do. So it's not going to be useful to some nurse out on a ward somewhere because they're going to give 1 ml, the patient stops breathing, and well, they're not in pain anymore, but that didn't do any good. All right, Alfenta is about 10 to 20 times the potency. Remifentanil is about 100, same as fentanyl, so remifentanil is the same. Hydromorphone dilaudid is the most potent opiate available to non-anesthesia people, to nurses on the floor and physicians and pharmacists and so on. And so you see hydromorphone is about 5 times the potency of morphine. So 10 milligrams of morphine is the same as about 2 milligrams of dilaudid. There's butorphanol or Stadol, nalbuphine, which is Nubane, and buprenorphine, which is Buprenex. Those 3 are partial agonist drugs, and there's their potencies. Heroin is 2 times as potent, so it's not really the potency that people like heroin for, but it causes the most euphoria. So that's why it's such a drug of abuse. And then look at codeine, 0.04. That's pretty weak. Codeine's analgesic potency is pretty much close to 0. But that's why they put a Tylenol with it. You look at Norco, and you look at Tylenol number 3s, the codeine and Tylenol. It's the Tylenol that causes the analgesia. The codeine just gives you a buzz. People like the buzz. So codeine's not really a very effective analgesic, but it does give you a little buzz, and people like that. That's why we use it. We'll talk about codeine as well. So that's kind of comparative potency ratios for some of the opiate drugs. You can see the ratios of ours are, of course, off the charts compared to most people. And for obvious reasons, we're trying to get people through surgery. Okay, any questions about any of that? All right, let's quit. I'm tired of talking. I'll see you tomorrow.